Welcome to the MEF2C cast, the podcast advocating for the MEF2C haploinsufficiency community by broadcasting the voices within. I'm Eli.
And I'm Haley. We are parents to a boy with MCHS and autism, sharing our journey with you throughout conversations grounded in learning, support, and community.
This is Advocacy Amplified. Do you have questions, comments, or a story to share? Want to be a guest on the show? Connect with the MEF2Ccast on Facebook, mef2ccast.com, or email us at mef2cast@gmail.com.
If you enjoy the show, please support us by subscribing to the show on Apple and Spotify, leaving us a review, and following us on social media. You can also buy MEF2Ccast merch at our Shopify store, linked in the podcast description. The MEF2Ccast is for informational and entertainment purposes only. Views expressed are those of the hosts and guests and not necessarily of the podcast or its sponsors. This is not medical advice. Consult a healthcare professional for medical concerns. Hi, everybody, and welcome to the MEF2Ccast. Today we're going to sit down with Elizabeth Laughlin. She's originally from Binghamton, New York, and she is now residing in Wheeling, West Virginia. Liz is a Doctor of Pharmacy graduate from West Virginia University's class of 2022. She brings decades of pharmacy experience, and she is currently working in a long-term care department, which brings a unique perspective that blends clinical experience with real day-to-day practical experience, which is especially meaningful for families and caregivers navigating complex care. And we're so glad to have her with us, and we're excited to share this conversation.
Alrighty, hi everybody. How are you today, Liz?
Good. How are you guys?
We're good. So Liz is here today to tell us about Leucovorin, how it works, kind of address some of the things around that because it's a very popular issue in our community. So can you just start by telling us the basics about, first of all, how's it pronounced?
Leucovorin.
Okay. I say Leucovorin and Haley gives me a hard time.
It's a big argument that we have because he thinks I'm wrong. So
yeah.
you were proving me right today. Thank you, Liz.
Anytime, Haley.
Yeah. So anyway, how does Leucovorin work? What is it exactly? And sort of how does it link back to autism and neurological disorders?
Yeah, so Leucovorin is a prescription form of folate. It's actually vitamin B9. And in some kids, it's actually not the issue of folate in their diet, but it's getting folate to the brain so they can use it effectively. So studies in some children with autism or language delay have shown improvements in communication, especially in children with certain folate-related immune markers. So it's not a cure, but it can be a helpful trial for families when carefully monitored. So basically what Leucovorin is, it's folinic acid, which is a reduced form of folate. And so your brain needs folate for brain development, neurotransmitters, and gene regulation. But some children actually have what's called a folate receptor alpha autoantibody. And basically what that does is it acts as kind of a barrier to the brain to allow folate to pass through. So what Leucovorin does is it kind of gives you a master key to allow the bypass of that folate pathway bottleneck. And then in some studies, it's been linked to gains in language and social communication.
Did you do any research on how dairy would interact with Leucovorin? I know that could be, some type of effect with that.
So dairy doesn't directly interact with it. So what we think of when we think of dairy products is whether it's going to actually bind the drug and make it ineffective. So it doesn't have the kind of charge on the drug that you would need for dairy to affect it.
Editing to add here that Liz wanted to correct her statement. Dairy is not a drug interaction. However, dairy, not limited to, but specifically cow's milk, can increase likelihood of developing FAA and theoretically make Leucovorin less effective. So we've had a lot of people say that their providers won't give them the Leucovorin prescription because they don't think that they can eliminate dairy from their diet. So that has been a huge topic around that as well.
Yeah, I think that there's a lot of research that still needs to go into it to see if there's a direct interaction. It's kind of one of those theoretical interactions that we see. And because of the non-FDA status of it for this use, I think a lot of providers are a little bit more hesitant around more of those theoretical interactions.
Another common form of folate that a lot of people in this sort of area take is 5-MTHF. So can you explain a little bit the difference between that and leucovorin, and sort of if there's use cases where one might be better than the other?
So, L-methylfolate or 5-MTHF is also an already active or methylated form of folate, so helps to also get into the brain a little bit faster. The main difference is that leucovorin can feed multiple different folate pathways, whereas 5-MTF kind of has one pathway that it can make through to the brain.
So there are people asking questions on whether you could take both together. So you would technically only need to take probably one at a time, you would think, right?
Yes, because ultimately the pathway is a saturable pathway, which just means that once you get to a dose that works, adding more doesn't really do more.
Right.
Yeah, you're essentially just you would presumably just urinate it out, like you'd just be
Yeah, it would have to work through the system, but
right,
you wouldn't be gaining benefit for the added dose.
right. You'd literally just be peeing your money away.
Essentially, yeah.
Right, yes. So well, let's take uh this route. What is sort of the state of research around leucovorin, and why is it controversial? What do we know? What still needs done? Kind of, can you address that a little bit?
Yeah. Leucovorin, the only FDA approved use for it is for um the reversal pathway for chemotherapy. So it came out essentially as a reversal to methotrexate treatment. So the research that is really happening right now is for cerebral folate deficiency is how they're framing it. So not exactly autism, and they're framing it mostly around those children that are that folate receptor autoantibody positive status. And what they're looking at is whether giving it to those children in certain time frames helps them to meet achievable goals. And so most of the studies have focused on an 8 to 12 week time frame. The most that we've seen is kind of 24 weeks, and that's really where they see if you've been taking it for 24 weeks with no change in benefit, you're really not going to see any benefit. So I think that's a good thing to think about is what achievable goals are we looking at? And what side effects are we also seeing for those kids? So, research right now is huge in this pathway, and the FDA is actually looking at adding an indication for cerebral folate deficiency. But they really need the longer term studies to happen before they know who benefits the most, the best duration, whether you can take it for a while and then stop taking it, and whether the skills will still be there, or if it's kind of you go back to that folate block kind of status.
What risks and side effects exist?
So, really, side effects of the drug that we've seen in this kind of population are activation. So, some families mentioned in those study data like hyperactivity, irritability, agitation. Some kids actually experience sleep disruption or insomnia. And then general with most drugs that you give kids, you run that risk of nausea, abdominal discomfort, which is why we do kind of that start low and go slow mentality. We don't start at a high dose. We start really low and kind of go in increments that we find safer than just kind of doubling, or which is why it's really important that if you've started the drug, you're not just increasing on your own. You're really working with your provider to increase the dose as is clinically.
Yeah, with Leo, we started, I think, at like a quarter of the dose, and then had, I think, 2 months of quarter dose, and then we just increased to half dose. So he's not technically even at a full dose yet, and we've seen some pretty significant improvements for him.
Yeah, and relative to the side effects, I mean, just as a layperson and a parent, when I hear hyperactivity and irritability, part of me wonders how much of that is just the medicine working, and all of a sudden your kid's talking more engaging with the world around them more, and you're like, "Oh my god, this kid's crazy." And it's like, well, their brain's just working more all of a sudden, and, I think that could account for some of it.
Exactly. I think we see a lot of those when we kind of label side effects, right?
Mhm.
If he didn't understand the language that you were speaking and now he's understanding 50% of what you're saying, that's a lot of that's a lot of gain for a child.
Right.
And when it's constant around him between school, TV, any animals, things like that, like I think irritability plays a lot into that, right? If you didn't realize your sibling was bothering you before and now you do,
Yeah.
that's definitely can account for some of the cool side effects that we see
Yeah,
when
or
you start use.
if you lack the capacity to vocalize properly, to express your displeasure in something, and then all of a sudden you can, make noises to express your feelings, that might also be interpreted as irritability.
Exactly.
Yeah. We talked about dairy. Is there any other, like, drugs or foods or anything that might interact with Leucovorin, things to look out for?
Yeah, so, it does interact, with several anti-epileptic medications or medications that can alter seizure control. So, the big ones that we see are phenytoin or Dilantin, phenobarbital, and primidone. What the researchers have said about it is that it doesn't automatically make the drug not an option for you. It just means that more monitoring needs to occur. If your child's been seizure free and on a med that has levels, so all of those medications can be monitored with drug levels. They just suggest more frequent monitoring when you start it to make sure that levels are staying at a level where seizure control can be monitored. And then obviously, not in this population, but like I said, methotrexate, this drug was developed as kind of the reversal or the rescue for it. So if you take it in combination with methotrexate, which is usually used now for rheumatoid arthritis or juvenile arthritis, sometimes it would obviously affect how that drug worked as well.
Gotcha. Yeah, I mean, the seizure thing makes sense as well because seizures are sort of an irregular brain activity, and if your brain activity increases overall, then of course the risk of that irregular activity would be increased as well. But if you're on a medication that can control that already, yeah, that all makes sense.
Yeah, it works, basically the enzymes that leucovorin break down affects how those other drugs break down, so you can get to more decreased levels of those drugs even at the same dose.
Gotcha. So the same dose would be less effective. Is that what you're saying?
Correct, yeah, it could be, yeah.
Would be, yes, of course. So, are there any sort of next generation drugs similar to this or anything like that in development right now?
Honestly, this drug is so old. It's one of those drugs that no one even knows really the brand name of it. So I don't see any in the pipeline right now. But I think as we move into this kind of science of methylation and the enzymes that our body has with our advances in genetics and things like that, I think we'll see more tailored drugs. So I think we're moving towards a point where we're looking at genetics to gain function of drugs like L-methylfolate that we talked about. They're using it a lot in patients with depression because it can actually help those drugs work better if you actually have certain mutations. So I think as we move into that period where more genetic testing is done, I think we'll see more of these kind of older drugs that fit into more niche spaces.
Right, so you'll be able to maybe use different combinations of things to customize the treatment to an individual.
Yeah, you'll know if this drug is more likely to work or not.
Right, yes, that makes sense.
Yeah. I was just looking at, some of the questions that people had, but somebody said, "What is the patho behind it? How exactly does it work inside the body?"
Yeah. Um, so it is I have a really good analogy that I came up with, so I'm just gonna find it here.
Love analogies.
Yeah, I think visuals definitely help you a little bit better with understanding kind of these more complex pathways. So, think of the brain like a library under construction, and folate is your building supply, and there's just one main door to get in. In some kids, autoantibodies actually jam that door. So, even though they have plenty of folate, the brain doesn't get what it needs. So, leucovorin basically finds a way to work around that blockage, basically creating another door. So while it doesn't teach language, in some kids it can remove that biological roadblock so that language and communication can finally start to move forward.
Gotcha. So those antibodies are binding to the folate that they're getting from their diet and not letting the individual actually use that
Yeah.
nutrient in its regular state.
Yes. And I have a feeling the next question that comes from that is can you test for those autoantibodies? And the answer is yes. There is a test. It's usually not covered by insurance because it is a genetic test. And so if that test comes back positive, it's just a blood test. It shows stronger evidence that folate transport into the brain is impaired, meaning that those children would show a greater average language improvement. However, a negative test there doesn't mean leucovorin won't help. Some kids still respond because I think we're still trying to develop how this pathway works. I think we see a lot of false negatives or kind of low levels of that antibody that aren't picked up on the test, and so any more folate into the brain could also help that. So, yes, there's a test, but it doesn't necessarily mean your child won't respond if they're negative.
So you said it and I missed it, but is the test testing for the gene that carries the antibodies, or are you testing blood for the antibodies themselves?
You're testing for the antibodies itself.
Okay, gotcha. Yeah.
And that's the FRAT test, FRAT, correct?
FRAA, yeah.
FRA, okay. Let's see. Big question that we got a few times was how to advocate for trying it. Um, what are some things that parents could probably go in with, just some basic knowledge things that they should know to go into a provider to say, hey, I would really like to try this for my child. This is what I know. What do you think about this? Because if you go in with knowledge and saying, hey, this is what I want to do, and this is why you should just go ahead and say yes to it, but providers are likely going to say no. But if you go in with saying what should I do with this information? What do you think your thoughts are there?
Yeah, I think that going directly at a provider and saying I want a drug is always going to have them immediately shut down. But I think going in with clear goals for your child and understanding that there's research in this area for the goals that you're looking for. Goals that they're saying that you should have for your child is 2 to 3 language or communication goals that you'd like to achieve. So, I mean, they could be small goals, big goals, but knowing that the research says, like, kids with this deficiency are reaching these goals in this population. I think the other thing to do is have other input. So, if you have a really good therapist that you're working with, if there's someone, an advocate within the office that you can talk to, I think those are key ways to make a provider kind of key into things. And I think being upfront with them and knowing that you understand that you might not see benefit from it. So I think providers are really hesitant to do things in populations where parents are really looking for kind of a spark or a really big change. And so being upfront with them and understanding that this drug may not work is, I think, a big thing because I think it takes a lot of their angst away. If you know that this parent's not looking for you to cure this, but just to make some small change to benefit your child.
What are the different forms of this? So I know Leo gets the compounded form, so can you go into that a little bit?
Yeah, so they make a tablet, and honestly, I didn't look up what strength it comes in, so but it does come in a tablet. We do compound it for certain populations, and that can come in flavored and not flavored. I think the liquid is the easiest way to do it because if you're paying for a concentration. So say it's 1 milligram per ml. If your doctor decides mid-month to try an increased dose, you can do it with that versus having to change tablet strengths.
Yeah, well, and something else that we should circle back on and touch on too, which you said earlier, is that forget the exact term you use, but there's like a saturation point with this drug. So you take it to a certain point, and then it your system absorbs as much of it as it can, and then the dose from there on is to maintain that maximum saturation. So
Yeah.
it,
So
go ahead.
right now, research is looking at the standard dose they're using is 2 milligrams per kilogram of weight per day. So they kind of have a standard that they're using. And not to say that you're going to, like I said, start out at that dose. You're probably going to start out at a quarter or a half of that dose to one, make sure that you're not causing the child any of those side effects that would make them not want to take it, right? If they can feel more irritable and they know they're not sleeping and they associate that with the med, you also see those side effects too, right? Try to
Mm,
get your kid to take a med they don't want to take.
Yeah.
yeah,
It's not fun.
right.
So they start low just so that you can kind of get used to any of those side effects, but also because once you've kind of reached that dose, that's where you stay. Sometimes kids do reach it at half the clinical dose that they're researching, but that doesn't mean anything. It's just because we don't know
Right.
Yeah.
where that dose needs to be. That's kind of they started at a point, and that's why we do research is to figure out where the real dose needs to be.
Right, and you titrate it to the individual. So, but yeah, that's and I think you mentioned this before, but that's also why it doesn't like you won't give your kid Leucovorin and then the next day see a significant improvement probably. It's going to take, I mean, it took in our experience a couple weeks I would say to see improvements in Leo, and then that's why, the long-term research is so important because it takes a certain period of weeks for it to build up to that saturation point in the system.
Yeah, right now in current research, the time frame that they're seeing for what they're calling meaningful change is 8 to 12 weeks, and their kind of cutoff point for not seeing any change is like 12 to 24 weeks. So if you've been taking it for a month for 12 weeks to 24 weeks and you haven't seen any benefit, it's probably less likely that the drug is going to give you any benefit.
Right. Yes, that makes sense. And then circling back to the talking to your doctor, I mean, just in my personal experience, if you come in to the doctor's office with an attitude not of like, "Hey, I heard about this. What do you think?" Like, "I'm considering this." The attitude I think you should have is, "I'm considering this for my child. I would like your opinion on it, and I would like the both of us to reach a decision together." If you come in prepared and educated, I think a lot of the times doctors, like especially in the US where they advertise drugs on TV, like there are a lot of people that come in that hear about a thing once and ask a doctor a question about it, and it's a whole can of worms and they just don't want to deal with it. But if you come in with confidence and some understanding, and like especially a primary care physician, their job is more of a facilitator than anything else, right? They can diagnose basic things, but their job is to help you manage the rest of your health. So if you say, "Hey, this is something I'm considering, let's figure this out together," I think they're much more likely to be willing to collaborate with you in that sense than if you just come in and sort of view them as the authority.
Yeah. And I don't think that there's a problem with you asking what their hesitation is. So understanding their side too, right?
Right.
You see nothing but benefit, but are they seeing something you're not seeing? Are they concerned about something that you're not seeing? So I think once you take that kind of perspective with them as well, like seeing what their hesitation is, you can work through that a little bit easier.
Yes, yeah, and also that's just kind of a good question to ask to see if you have a good doctor or not, because it's possible that you ask them the question and they don't really know, or there's some other like, just some not a good reason. And then you can go find a different doctor. That's not to say you should go shopping around for doctors, but until you find one that'll write the script for you. If they have a good reason, then that's a good reason. I think it's important. I mentioned this on the show before. It's important to remember that doctors are just people, and like doctors and like the medical institution as a whole, we should hold in very high regard. But any individual doctor could be good or could be bad, and you have to vet that yourself and not just, look at the letters in front of their name and assume that they're trying to use the right word without sounding rude. Assume that they're a good fit for you, I guess.
Yeah, and I think the other thing you, can think about is that that decision doesn't need to be made at this appointment, right?
Mhm.
You can bring it up to them and then say, "Okay, well, you're hesitant. Is it possible that you could do some more research into it, and then we can discuss this at our next appointment?" Giving them the time, because none of us like to be put on the spot, right? If I don't know something about a drug, I'm gonna tell you, like, "Give me a few minutes to go do some research, and I'll come back up and talk to you about it." I'm not gonna go into that blind, so allowing them the time to do their research and understand what you're asking, right? Because all they're seeing is they type into the computer Leucovorin and it comes
Mhm.
up as a chemo fix. Well, why do they wanna give this to a young child, right? So, giving them time to understand it as well.
Yeah. Yeah, I had an experience with that, not with Leucovorin, but personally for a medication where I was on where I went to the doctor's office and said, "I'm on this blood pressure medication. It's giving me a cough. I'd like to try this other one." And they're like, "That's not a blood pressure medication." And he said, "Okay." And he looked it up and he said, "Okay, they do use this for blood pressure. We'll try it and see how it goes. If it works, great. This is something I can recommend for other patients. If not, we'll try something else." So, again, doctors don't know everything, and it's unreasonable for us to expect them to know everything off the top of their head. So it is okay if they need to go look something up. They're more equipped to parse through the information that's available and make a decision than the average person. So,
And
that's go ahead. Sorry.
honestly, if you have a doctor that's willing to go do the research for you, that's probably a better fit for you than
Absolutely.
someone who just says no.
Right.
Yeah. Another question that somebody had, is one or the other better, like the 5-MTHF versus the leucovorin? I know they both work a little bit differently, but, like, could one be better?
So, honestly, if 5-MTHF is your only option, then that's, a viable option for you, right? It's going to give you the methylated folate to help with language function. Where we see the leucovorin work differently and, through the mechanics work better is because, it works on the receptors itself as well as methylating the folate. So it gets the folate by multiple ways, so you end up with more getting into the brain. So, in theory, leucovorin is better in that way because you have more options on how to kind of get around the block, but MTF gives you the methylated folate itself to kind of help with that barrier.
So, what does leucovorin do to the receptors? I'm sorry.
So it helps to work on that blockade, so it can help to move those autoantibodies off.
I see. Okay, gotcha.
So it helps the receptor as well as getting the folate directly in.
So it performs the same function as 5-MTHF and also makes the person taking it able to absorb more of that methylated folate, correct?
Correct. Yep.
Okay, right.
That's the theory mechanism.
Right, right, right.
Obviously, we don't actually know how it works
Mhm.
because we don't have a way to like look inside your brain when you take it, but
Yeah,
that's what the researchers are proposing.
it's crazy how much of the world is like that. Is like, "Oh, we think we know, but,
Yeah, there's like probably 50% of the drugs that out there that are like, well, this is how we think it works.
Mhm, yeah.
It's crazy. Um, do you anticipate leucovorin becoming more accessible in the future?
So I think we do have kind of a backwards kind of way into it being more accessible. So in September of 2025, the FDA started looking at leucovorin for cerebral folate deficiency, which overlap with some autistic features. So I don't think we're going to see a FDA indication for autism, but I think we will for cerebral folate deficiency. And so if you can get the testing done and your insurance will cover it for that disorder, I think we'll see more insurance coverage. And once we have insurance coverage, that's when Big Pharma moves in and tries to make those different formulations that would be accessible to kids. So it might not need to be a compounded product. It might move into a product that would be more commercially made. That's all speculation based on what we're seeing with what the FDA is doing, but usually that's how it moves. We get a new indication and then more research kind of gets thrown to that indication. And I think with how big research is around autism and language disorders right now, I think we're going to see more and more research come that way.
It makes me wonder, just based off of this coming kind of out of the blue, like what else is out there that would be this beneficial for our kids?
Well, that's what I think with more of the genetic testing being done and its cost coming down, I think we'll see more of that kind of customized medicine coming about. We're going to see have a snip on this and this and this. So this blood pressure med isn't going to work for you, but this is. We've seen it kind of when we've done kind of race related research where we've seen different blood pressure meds work in different races at different efficacies. So I think when we see this kind of genetic spike that we're seeing, we're going to see more of these older drugs come back in and understand things that work. So like dextromethorphan, which is in cough syrup, they've now linked to a depression med to make it more effective. So I think we're going to see a lot of these little drugs that have been around forever kind of come back into the fold for different reasons.
Yeah, well, and the other thing is too with sort of advances in technology and like AI and machine learning. I know when I was at West Liberty, and I just saw an article not too long ago that one of the professors from West Liberty spoke at a conference about a drug he had found through some sort of machine learning algorithm where they can take a given condition or gene variation or whatever and run literally thousands, millions of known medications through this program, and it can narrow down to things that would likely help, and then you can start testing from there. I think, that as those things advance, that's really going to speed up drug development. If for no other reason, then it'll just narrow our search a lot quicker.
Yeah, I think a lot of drug development is right now is kind of like we see something that works that your body makes that works well that somebody might have a deficiency in, and then we try to make a synthetic form of it. So I think once we can start working with our body more to make the drugs kind of fit the body instead of the body fit the drugs, I think we'll see a lot more of advances.
All right, do you have any other
Yeah.
questions?
No. Did you have anything that you wanted to touch on, Liz, that we didn't?
I think the only thing I would wanted to be super make sure is that once you start on Leucovorin, it's kind of one of those things that that when you see a benefit, you want to just keep you want to increase the dose and you want to do this, and it really needs to be a conversation with your provider for a couple of reasons. You don't want to move to the negative side effect of things, but you also want to make sure that that provider is willing to be the same for the next patient, right? So if you go rogue, they're going to be way less likely to give it to the next parent that asks about it, right? So understanding that our use of drugs and the technologies that we have comes at a cost, right? You're the guinea pig for the next person. I think we've seen that with several of our providers locally. Like they've seen some benefit in kids, so now they're very on board with it. But if they start seeing the negative side of things because we've increased the dose too quickly or things like that, you also become a detriment to your community as well. So understanding that those open and honest communication with your provider is key to not only making the drug more accessible, but making sure that the drug is safe and effective for your kid.
Gotcha. Um, just circling back to one more thing as well. So as we said, you take the drug until you hit the saturation point, and then you take a maintenance dose from there. Well, it's the same dose, I believe, but it's a maintenance dose from there. So presumably, once you start it, you hit that saturation point, and then you're on it indefinitely, right? Like there,
So
it are. Go ahead. Sorry.
that's what research is saying right now. I think as we get into these longer term studies, they'll do a point where what they do is call it yourself as a control.
Mm,
So they would take half of the kids that have taken it for 2, 3 years, and then they taper some of those kids off. And then they measure their function from there. So did they maintain the skills that they've learned, or did something not happen? What I think we need to understand is that there's a ton of drugs that are lifelong, right? So as long as the child's not experienced any negative side effects, that nothing's gone awry, we have a ton of drugs that everyone takes lifelong. It being a lifelong drug isn't necessarily a bad thing, right? And I think that's where we go to with our kids, right? We don't want them to be on drugs their entire life. But if it's improving their quality of life, it's worth them taking a med every day.
mm,
Yep,
yeah.
of course.
And it seems like, I mean, we probably don't know for sure, but it doesn't seem like, some medications, like again, my blood pressure medication, like if I stop taking it tomorrow, I could have rebound hypertension and that could be dangerous. But it doesn't seem there would be a whole lot of risk if you just quit taking Leucovorin tomorrow. Like you might regress some, but as far as like actual risks to your health, it from what we know so far, it doesn't seem like that those are very prevalent.
From what we've seen, because obviously, those kids in the study, some of them at that 12-week period had experienced no benefit, and so they were taken off of it.
Mm,
So, from what research is showing right now, there's not any negative negative, detrimental side effects other than the chance of regression, but there's not going to be anything that makes it a more deficit than when
right.
they started.
Yeah. Yeah. Gotcha. All that to say that, like, if you're really worried about them taking a lifelong drug, like, you could just stop at any time you wanted and it wouldn't harm them other than them possibly losing the progress that they've made.
As long as they've
From
talked to their provider.
Right, right, right.
Yeah.
Yeah.
Yeah. Yeah, the
Obviously, yeah,
honest
all of this
conversation is with your provider, for sure.
yes, all of this is to be discussed with your doctor.
Mm.
So, yeah, definitely. Anyway, that's all right. So, thank you for your time, Liz. Thanks to our guests for listening. They can contact us on Facebook, the MEF2C cast, email us at mef2cast@gmail.com. Website is mef2cast.com. If you want to support the show, visit our Printify store, go to our link tree. We have Amazon links on there to some of our favorite toys for Leo. And thanks everybody for listening.